Hello, my name is Joanna Tovar and I'm a nurse practitioner student. What's your name?
Nice.
Hi, Anais. Nice to meet you. I'm going to be recording a video for the cardiovascular assessment and a peripheral assessment as well examination. Do I obtain your consent to upload this video on YouTube and film it for educational purposes?
Yes, you do.
All right, thank you. So, for starting our cardiovascular examination, we're going to start by coming into the room. When we come into the room, we would make sure that the patient has had her vital signs performed. What we'd be looking for would be the bilateral blood pressure. So we would have expected the MA or nurse, whoever would be, to get bilateral blood pressures with the patient supine and the patient sitting. Approximately 5 minutes apart, and we would be observing if there's any differentiation or any signs of hypovolemia or anything like that with the blood pressures. After observing that, we would move on to our neck examination. So we would make sure that the patient doesn't have any obvious jugular venous distension, which would be often be seen in patients with cardiac diseases such as fluid overload. So I'm gonna have you move. We're gonna be moving the patient to this side, and I'm gonna have her lay down at a 30 to 45 degree angle. Sorry. Okay, and then I'm gonna be using a light, and we're gonna be examining where there is the internal jugular, where the pulsations are coming up to. So I'm gonna have you turn your head to the left, Miss Anais, and I'll be standing on the right side of the patient, and we're gonna shine the light. Okay, and then we would use our point of to mark the where we see the oscillatory or the pulsations coming up to, and we would use our ruler and measure at a 90-degree angle. So the patient is at a 1 centimeter, which is a normal finding. We would want the jugular venous pressure to be less than 3 centimeters. So since Miss Anna is at a 1 centimeter, it would be a normal finding. So after doing that, we would move on to assess the patient's carotid pulses. We're going to be palpating the pulses and making sure the amplitude and regularity of the pulses. We want to make sure that the carotid upstrokes are brisk and that there is no thrills noted. We would palpate one at a time. We never want to do both at the same time, because that could cause that could stop blood flow to the brain. So we're doing both at the same. We're doing one at a time. Sorry. So carotid upstrokes are brisk, and there is a 2+ pulse, which is a brisk expected rate on the pulsing. So after that, we would go on and listen. So we're going to listen to see if there's any bruits noted in the carotid arteries. So we're going to listen with the diaphragm and then with the bell. Can you hold your breath? Okay. Then move on to the other side. Okay. Then we would turn it around for the bell. Okay, so there was no bruits, no thrills heard upon auscultation. So then after that, we would be moving on to the chest. And the chest, we would have the patient, for this purpose of the exam, we're going to have the patient with her clothes on, but in a clinical setting, we would expect the patient to be, it would be done in a bare chest. So we would have the patient, we would be inspecting the patient's chest, making sure that their sternum is midline, that there isn't any depression in the sternum, which could be indicative of pectiv excavatum. We're going to be making sure that there isn't any pulsations, no precordial or apical pulsations noted, or if they are noted. Usually, depending if the patient has musculature, it would be hard to observe. But if a patient does not have a lot of musculature, these pulsations are a little more common to be found. And if the patient is thin and cachectic, it could be another finding with the musculature, with the pulsations being present. After inspection, we're going to go on to palpation. So we're going to be palpating the 5. We're going to do 5 because we're going to include the herbs point. And I'm gonna place my hand on your chest, okay? So I'm gonna stand on the left side of the patient so you guys can see a little better. And I'm gonna be palpating the right. I'm gonna put my hand in the middle, and I'll pat the right, which would be the aortic, and the second intercostal space in the right side, and we're gonna be we're palpating to see if there's any thrills, leaves, or lifts. And then we're gonna be going to the left side, and this is the pulmonic in the left second intercostal space, in the left sternal border. And then, sorry, I'm gonna have to move. And then we're gonna be doing the Erb's point, which is in the third intercostal space. And this is in the left side as well. And then they're doing the tricuspid, which is in the fourth intercostal space in the left sternal border. And then the fifth, which would be fifth mid-axillary left side, which is a mitral valve. And in this point, we're also going to be palpating for the point of maximum intensity, which is where the impulse of the left ventricle, and a normal finding would be a tapping sound, which would be the left ventricle pulsating towards our fingers. If this would be hard to be felt, we could ask the patient to turn to the left to feel this a little more. Okay, thank you. So after doing that, we did the palpation, so now we're gonna be auscultating the areas. So actually, before we auscultate, I need to palpate, the abdominal aorta. So for the abdominal aorta, it's gonna be in the above the umbilicus, and we're gonna be palpating, checking the width of the abdominal aorta. A lot of the times it could be felt a little more on the left side of the patient, and we're just going to be making sure that there isn't any pulsatile masses, that there isn't any bruits or thrills noted, and there's no bruising and inspection. So no abdominal aorta pulsatile masses noted, or bruits or thrills noted. So after doing that, we're going to be moving on to auscultation. So for auscultation, we're going to be auscultating the four different parts with the diaphragm first. And we're going to be checking that there is an S1, S2, S3, S4, or if there is any clicks, murmurs, scallops heard. So we're going to be doing with the diaphragm first, as I mentioned. And we're going to be doing on the aortic, pulmonic, Erb's, tricuspid, and mitral. So the second intercostal space in the right sternal border. The left intercostal space in the left sternal border. The second intercostal space in the left sternal border, which would be the pulmonic. The third intercostal space in the left sternal border, which would be Erb's. And the fourth intercostal space in the left sternal border, which would be the tricuspid valve. And then the mitral, the point of maximum intensity, also known. And we would notice that we would make sure that there's a regular rate and rhythm, that there isn't any gallops or murmurs or thrills noted, as mentioned. Now we're going to be checking with the bell of the stethoscope, the same areas. And when we're auscultating, we want to make sure that there isn't any splitting of S2. A splitting of an S2 can be normally pronounced when the patient is taking a deep breath, but a lot of the times it could be caused by the pulmonic and aortic valve closing separately. Usually they close together, which would cause the splitting of the S2 sound to be heard. We can also ask the patient to lean forward, and we're going to be listening and auscultating to see if there's any aortic insufficiency murmurs that could be heard. Okay, so no murmurs or clicks noted. So after doing the auscultation part of the chest, now we're going to be placing the patient on the side, and we're going to be moving on to the peripheral portion of the exam. So we're going to start by inspecting the upper extremities. The upper extremities, we're going to be checking that the patient, we're going to be inspecting and palpating at the same time, bilaterally in both arms. So we're going to be touching, making sure that there isn't any varicose veins, that there's no edema, no shunts in place, that the skin is pink, warm, and dry. And then we're going to be checking the capillary refill of the patient, checking that the blanching is less than 3 seconds in bilateral hands, and that there isn't any clubbing or no clubbing present, and that there is no tar in the fingernails, which should be indicative of smoking. So now we're going to go checking on the pulses. The pulses we're going to check bilaterally on the radial pulses, which would be 2+ brisk expected normal rate. Then we're going to go to the brachial pulses, which is a 2+ brisk expected rate as well. Now we're going to be going on to the femoral pulses, and for this one we're going to be auscultating and checking for murmurs. And right now that we have the patient laying in a little more comfortable position as well, I'm also going to be auscultating the aorta, which I did not auscultate initially. So we're going to be auscultating the aorta, checking if there's any bruits or thrusts noted. And then, so no bruits, no thrusts noted in the aorta. Now we're going to be doing the femoral. And for the purpose of the exam, as mentioned, the patient would not have pants on. It'd be under a gown and bare skin. So no bruits or thrusts noted in the femoral artery. Since we're there already, we're going to start with the pulses, which should be 2+ brisk normal rate. Then we're going to go on to move on to the popliteal pulses, which would be on the bottom of the knee. And we're going to be checking bilaterally. And then we're going to be checking the other one. So that was 2+ brisk regular rate. Then we're going to be checking the dorsalis pedis pulses, which would be, and the great toe, we're going to be checking bilaterally as well. On the top part of the foot, and that's 2+ brisk expected rate. Now we're going to be checking the posterior tibial pulses, which are located in the medial aspect of the foot, right behind the malleolus. And that also is a 2+ brisk expected rate pulse. So now we would also by the time be inspecting the patient's skin color. We're going to be checking that there isn't any edema noted, no varicose veins, no tenderness, and that the skin is pink, warm, and dry, no cyanosis noted. We're going to be checking the capillary refill of the toes. So we're going to be making sure that the blanching, that there is less than 3 seconds, that there isn't any abnormalities, and that I believe would conclude our examination of the peripheral vascular examination and our cardiovascular examination. Thank you guys for watching.